Hey, everybody. Happy New Year, even though it is the 8th day of January, but it is the first time that we as a panel are all back together. So I want to begin by welcoming Terry, Scott, Paul, Christine, and Stephanie to the first Compliance Guy Roundtable of the year. I know we've got some interesting stuff to talk about today. Um, the panel was encouraging me to use bad language, but this is a family show, so we're going to keep it PG for everybody. Um, Plus, I have to notify Spotify if there is bad language, and then they put these flags on the podcast, and it's just I'd rather not. But if one of you guys is so compelled, Christine, you know, have at it. All right. So, to each and every single one of you joining us from around the country, around the world, depending on the time zone, good morning, good afternoon, good evening, bienvenue, buenos dias, buenas tardes, buenas noches, ciao, como está, and welcome. All right. So, today I know we have quite a few discussions that we want to have, and I think the most interesting one that we're going to start with is the G2211, not G2111, as somebody posted on LinkedIn today. It is G2211. And for those of you that are not familiar with that, let's go ahead and jump right in. So, Terry, I'm going to throw you into the hot seat first because you wanted to talk about this topic and you actually had something pretty interesting with a client of yours who sent an email about their spouse wanting to build the code. So let's talk about what it is,
Yeah.
why it was created, how it's supposed to be used, and then the do's and don'ts.
Okay, so the G2211, this is what they call a patient complexity add-on. So a patient who has a serious condition or they have conditions that are complex in nature where CMS felt that the E&M value was not enough to represent what goes on with that, and I'm going to air quote, longitudinal relationship with the patient, meaning you're taking over that part of their care for a long period of time. They have not defined what long period of time is, and it was primarily set up, and actually remember we were supposed to have it in 2019 for primary care physicians. And then they said, or other specialists or other specialties. And that was opening a whole new can of worms because now I have specialists from you name it out there saying, well, I'm going to use it. I'm going to use it. And then they didn't put frequency guidelines on it. They haven't told us anything about if another doctor bills it at the same time another doctor bills it, what if they share a diagnosis? Will one get canceled out each other? And we just have a mess right now. The other thing is everyone's trying to tie it to diagnosis and not individual patient issues and complexity. And so, what I had with a client, and this isn't a negative about a client, it's just this is how they're looking at things. And it's really concerning me because if one is doing it, you wonder how many others. They want to automate it. And they want to basically say, I thought about Paul Spencer when I heard this, because I know Paul and I have these shake your head moments all the time. We're like, seriously, faceplant, where they said that they want to just have it so their computer, so the coders automatically just put it in whenever there's an E&M service for a patient. And I'm just like, no, no, no. And did I say no? Because first of all, it's kind of like saying every patient that has two chronic conditions can have chronic care management. No, you have to reflect there's guidelines on that patient, is susceptible to decompensation, to dying in the next couple of years, to readmissions. Well, I look at this add-on code as a very similar type of add-on service, and the expense is that this is to really help those physicians that are involved in a patient's long-term success or goals, or um, trying to deal with their complexities and I guess I'm going to say on a peripheral basis. So everything that goes with that, and hopefully helping them with that expense. And I'm going to send it over to the next person on this. Where the problem lies in this is that the codes that are The base codes that go with this add-on code are 99202 to 205 and 99212 to 215. Where I have a hard time with this is, how do you know that this is going to be a longitudinal relationship if you attach it to a new patient visit? That makes no sense to me because you haven't established that relationship yet. So, because they have not set up guidelines and CMS has this, I don't know, fantasy land that it's only going to be used 38% of the time, when I have people out there saying I'm going to do it all the time, I don't know. I think this is a way to step into invited risk for inflating an AR and having them say, oh, let's look at this practice and see what they're doing. So to me, this code is a mess. And there's a couple of new codes that are out there, G codes, which means G, we're watching you. Don't forget that. In the HCPCS side, that I think are going to cause all kinds of headaches. Another one's SDOH. There's just all kinds of things going on. But I'll throw it over. Scott, how about you? What do you think about this code?
So I've been debating whether I'm going to lose the whole audience with this or half or however, but I don't know.
That's why I started with you.
I don't know how many Star Wars people there are out there, or how many meme people, but I think about at that Admiral Akbar meme where he's like, "It's a trap," and it is a trap. I think potentially when you add it liberally to services, because I think it's very poorly defined. I think it is a prime audit target, and I think internally you have to set very conservative metrics for when you're going to use this code based on the nature of the patient relationship and the conditions the patient has. And when I think about, and maybe I'm overthinking it in some cases, but when I think about complexity of a visit, I mean, I see plenty of visits in my audit work all the time where the patient has multiple chronic conditions, but the visit is not particularly complex. And the visit doesn't really reflect any sort of longitudinal management. It's just it's very and this is in some instances a byproduct of documentation, right? Where it's very much a drive by. You've got this, you've got this, here's your new meds, I'll see you in 6 months. Is that complex? Am I talking about how these conditions affect your overall health at the moment? Am I talking about risks of complications in a meaningful way? I'm not just saying like you have risk of complication, and so I think there's a lot of layers to this onion that go beyond just saying, do I see this person all the time, right? I know when you talked about new patients, I thought about, those people that exist in the world sometimes. I haven't gone on a first date since like the early 2000s, but these people at the end of the first date and they're like, so are we dating now? Are we in a relationship, right? So I think the same thing applies, right? How do you know when you're going into that longitudinal relationship? And so for me, I think you really have to rethink your documentation when you get on this path and ask yourself, am I doing, some of these things we talk about, or at least I talk about with the 2021 guidelines? Am I being illustrative in my history as such that I understand the patient's condition today? And I think, where people are going to run into trouble with this is this notion of, like I said before, the kind of drive-by documentation where it's like, hypertension stable, refilled meds, COPD stable, refilled meds. And I just, as I often say to providers, I reflect the complexity that you show in the note. And so, if it's not complex from a documentation perspective, it doesn't matter what you verbalize to me, it wasn't particularly complex. And so I have a lot of concerns about it, particularly the fact that I think, as we said last year, there are going to be providers who just apply it every single time they see a patient. And I think 2 or 3 years down the road, they're maybe going to wish they didn't do that.
Well, Scott, you're absolutely right. And I think that if we look back historically, that's why the moratorium was placed by Congress on this, because they originally said in 2019, whoa, we think everybody is going to overutilize this code historically. And the other thing that you said that was really interesting is we still have those providers that are, die hard, GEMS mapping, unspecified to unspecified conditions. So, like you said, how are we even going to support longitudinal care or that that relationship when we still haven't even been able to get our providers to provide more specificity for those patients. I see the uncomplicated diabetes, but then when we look in the medical record, this patient has been hyperglycemic for 6 months. They've tried multiple medications. Their glucose levels are rising and falling, and we're getting that standard E11.9. So if that continues and we haven't been able to fix that in all these years, how are we going to be able to support this not G2211 that really is meant for that longitudinal, that patient that's going to require a little bit more, maybe that doctor who didn't get the message for virtual check-ins, who is doing extra phone calls, who doesn't have chronic care management, those types of things that G2211 might support.
So that's a good point. And, one of the things I've been thinking of is, how am I going to train anybody on this? I haven't had to do that yet, but my time is coming very, very soon. So it's like, I'm like, okay, I got to get my head around this to some degree because I'm going to have to be training on this soon. And, one of the things I keep going back into, and it makes me question how this fits with our leveling, but when I train a level 4, for example, when we just think of presenting problems, I always talk about the fact that I should not just see point and click documentation. So I should not go into the assessment, see the name of a condition in your order, and that's it. We need to know what they're thinking. So the one thing that I'm personally really struggling with when we think about the relationship, or Pam even has a good comment here about investing, the provider investing in the relationship with their patients, and what that means in between the visits, and how that looks for a whole year when they're caring for a patient. To me, that's everything that's between the lines, and we don't even usually get the basics, like you're saying, Christine, in a visit, from diagnoses or anything else. So for me, one of the first things I'm thinking of is, I don't see how we could accomplish this and support this, or even have to defend down the line very well, if we don't have free texted documentation. All of this is pointing towards the thought process of the provider, the core basics of auditing when we are not making our own assumptions about this. So automating it's going to be an issue. Another thing too, and Terry, I think that you brought this up at some point, is if we're to look back historically at the billing information, what do we do as an auditor if they want to add that G2211 to everything, like we're talking about, or most patients? What do we do if the patient has, 10 diagnoses, but yet they only came in once that year and we're towards the end of the year? Is that showing that they've created this relationship? Is this showing longitudinal? There's a lot of unknown, and it's really hard to navigate in the beginning before we get more in writing from the payers. But this is a lot of what I'm trying to think of. More so, if I have to defend a provider in this, what am I going to be able to use in documentation to do that? And it's going to take extra work. We don't have extra money without extra work, and I think people forget that as well. Now, one other thing, when I was talking about tying in the leveling of service, to me, if they give us that detail, that may be something that supports a 4 instead of a 3. So, the guidelines are saying that they get to do this additional. I don't think that because we can support a 4, we don't support G2211, but it's just kind of going hand in hand to me right now as I'm trying to navigate it. Paul, what do you think about that?
Well, I wanted to get back to your point about how to train for this. And I really think there are 3 key words that are part of the code that really have to drive any training that we do for this code. And that is continuing, serious, and complex. I mean, those are the 3 key terms that we have. And it's funny that Christine talked about diagnosis code, because as Terry was talking, I scribbled the words complexity ICD-10 right on this pad of paper, because I wanted to make sure to talk about it. One thing that we talked about by email before we even jumped on the air was the fact that we don't even know if Medicare Advantage is going to reimburse this. But you can bet that if Medicare Advantage is going to look at this at all, they are sure going to tie it to risk adjustment. And there better be some quality ICD-10 diagnosis codes. There better be some combination codes that are in there if you have a patient who is coming in with diabetic kidney disease or something that has manifestations in another organ system. This better be that serious or complex condition that they're working on. It's not going to be like, oh, you have a hypertension of 140/90. Oh, we better do some extra work. That's just not going to cut it.
One of the things, and Scott, I'm going to come to you because I know you had a thought on those. But one of the things that jumps out to me, anytime you have an add-on code, and I don't know if it was Christine or Stephanie or Terry, one of y'all said, there's no extra payment without extra work. And one of the things that I think should be the key takeaway from this discussion is that anytime you are adding something onto a claim form that you expect to be paid additional remunerations for, you have got to make sure that if you are in your EMR system, you are free texting. That is the only way. There are no smart phrases, at least at this point, that I can think of that should be put into an EMR system. And again, I'm not a fan of some of these smart phrases. I think there's a point in time where they're appropriate. But if you're trying to create smart phrases to fit every situation, every scenario, it doesn't work. And auditors will catch on to those things. Um, take the time to go in and free text and focus on the three terms that Paul Spencer was talking about, but primarily the complexity. And again, make certain the complexity of the diagnosis codes are there to substantiate why this is being done. Um, Ginger has a good comment that she's made here, which is if it's worth an extra code, it's worth an extra paragraph or at least a few sentences. And I think everybody on the panel has agreed. I think Terry was the first person to say, "Hey, Ginger made a great point. Let's share that with everybody." We agree. If it's worth an extra code, it's worth additional documentation. All right. So Scott, I
Throw
know
it
you
back to
had
Scott a second, yeah, because I have
yeah.
a question on that.
And Sean, I think what you said feeds really nicely into my thought. I think, if you are listening and you're thinking about your own organization internally, I think it's pretty critical that you wrestle down how you're planning to use this code or how your providers are applying this code before it gets out of hand, before it gets out of control, and there's a lot of variance in its usage. One of the things that I think about sometimes as a non-clinician auditor, when we think about the 2021 guidelines and this construct of a medically appropriate exam or a medically appropriate history, and I sometimes step back and I say, well, how do I come behind like a licensed physician and say this is medically appropriate or this is not medically appropriate? The same thing applies here, where I could envision scenarios where the physician comes back and says, well, what do you know about complexity, right? Like it's very complex for me to manage like this condition and this condition concurrently. And so, it's important for us to assert from our role that it's the documentation that determines the appropriateness of payment. So it is that extra paragraph, it is that extra few sentences, as Ginger said, because we have to defend the work. And the way you defend it is you document, you don't come in behind it and say, well, of course this is complex and you don't know what you're talking about. And I can see this leading to some of those kind of conversations. So I think it's important, internally that you're on top of this from the get-go, because you're going to see this coming through. And I could see this being a runaway freight train, just in terms of this thing going from 0 to 60. It didn't exist last year, and now it's on every claim.
But the other thing, and also, let me finish with this
Go ahead.
Sean, is that I think when offices are doing, and this is where I'm finding it's going to be a problem, every time there's an add-on code like this, or every time there's an extra revenue opportunity, they look at it more as a revenue opportunity instead of a patient opportunity and that relationship. And what I'm seeing is, how can we template this now? How can we just have a quick drop down, add in, plug and play statement where it fits one for all? And that's where I see this is going to be a problem.
But
And so it's just opening up a can of worms. So I think for direction on how to do this, and I know NAMAS has some things up there as far as doctors management. I know I put something on my website. I know Christine has stuff too. One of the things you have to consider first is everything we're doing now since the 2021 guidelines changed, it's for individual patients on what you did today. It doesn't matter about the diagnosis. It matters about how you are addressing their problems. What are you doing today? What are you doing with that patient? And not what you're doing from a generic standpoint that's a one size fits all. And I think this add-on code is a perfect example of not doing things in a general sense. Otherwise, it's really just adding it on to try and get that extra $16. And I have a problem with that.
No, and I think you're spot on, Terry. There's a comment that was posted into the LinkedIn chat by Maya Turner, and I think it's an interesting question. And I know you had some additional thoughts, Christine, but I wanna ask this question to you and anybody else on the panel as well. She says in the code description it states chronic conditions. Is it implied that long term is longer than 12 months? It certainly is implied by the code descriptor. What do you think about that, Christine?
Well, a lot of times when I'm talking about chronic conditions with providers, I remind them that these chronic conditions are conditions that you have to actively be involved in order to bring them to a stable position or to eventual resolution of this condition. That definition comes straight from the CDC. So oftentimes when we talk about the chronic condition, I argue sometimes with dermatologists who will tell me, Christine, the patient has a seborrheic keratosis or an SK. Okay, but what are you going to do about it? Well, nothing. Well, if you're not going to do anything about it, then how do you say that that's a chronic condition? Because that's just something that you're saying they're going to have the rest of their life, but we're not actually having to manage it to make it stable or to address it to make it stable. So I go back to chronic conditions are conditions where the provider's intervention is required to make them stable or eventual resolution. So we need to show that that's there. Maybe that's in the plan of care, where the plan of care shows what that longitudinal relationship is going to be. I will see the patient every 3 months to make sure that the medication is working, that we've gotten on goal. And I think Maya's absolutely right. What does that look like? Is it going to be that 12-month period or the rest of their life, as we see that in definition in some of the other things that we apply the definition of chronic condition to, like in chronic care management? The other thing,
Christine, did you notice that they didn't say chronic in the definition of this? They said serious or complex.
Right.
Serious. That's right.
Right.
Serious,
They didn't say
complex.
chronic. Yeah.
Right.
So again,
And
what does that look like? What does that look like from that provider's perspective? How are they going to show that serious or complex and longitudinal? And I think one of the things that it concerns me the most that we've been talking about here is providers wanting to use a macro or the fill in the blank or click a button. And my concern is that I audit a lot, just like you, Terry, Scott, Paul, Stephanie. We are in these medical records all the time. And what we see historically is that the templates are bad, or they're old, or they just are not helping the providers. Providers,
they
in my
just don't fit.
opinion, yeah, they're doing more work than what they need to from a payment perspective. Clinically, if you want to write 12 pages of notes, more power to you. From a reimbursement perspective, those 12 pages don't make you that give you a higher level of E&M. It actually makes it more complex and it presents more problems. So we've got to get into those templates first, revamp them, get rid of them, go back to free text, go back to the SOAP note, go back to that documentation, and then think about the fact that not one size fits all. You can't use the same template over and over and over again to try to support something like this new add-on code.
You know, Terry, I want to come to you for a moment because, again, CMS doesn't always come out immediately with guidance when new codes are published. But as time progresses, as they review documentation, through ADRs, things of that nature, they start to pick up on things. They start to recognize trends. So talk a little bit about what CMS has done to kind of educate the masses to this point on what does not support these services and what is not a G2211.
Right. So it's interesting you say that because, and I know I put in our chat, one of the things that I thought was interesting, and Christy and I actually we go back and forth on this, and it's really nice to have that open discussion because her and I pull out our hair quite a bit. So we're like, okay, can I just rant today? So we'll call each other and go, okay, here's the problem. But one of the things that CMS does is they always tend to put out, first of all, how great they are. We did this and this for you. And then they give you a zinger about, well, this is how you use this code, or this is how this regulatory guidance is going to work. But what I noticed with the G2211 is that they told us what not to do. It's kind of like what not to wear. They basically came out and said, well, this is not a G2211. This is not the provider we would expect to use this, meaning surgeons, because they figure once you're done with the surgery, it's done. But then I look at, surgeons who are dealing with cancer surgery and things like that. So they came with a couple of conditions. They did like lesion removal, simple flus. I thought that was interesting, but they had a lot of interesting guidance about it. But it was all what not to do. They didn't say, well, here's a list of diagnoses that are appropriate. Here's a list of serious conditions. They didn't say that. So it was all about the I don't want to say the negative, but more about the discouraging part of what not to code versus what they expect. And maybe that's what they're thinking. Okay, so if you're going down this path, this is what we don't want to see. But if you're going to do it, then you take your chances. But I think just because I know we have other topics to do, I think that everyone has to keep in mind, and I've heard Sean say this all the time, be careful with invited risk. And like Scott said, be careful with that trap. I think this is just, oh my gosh, it's just a hotbed for it. Not discouraging you from using it, but you're also going to, and let me be clear on this, you're going to get specialty societies, primary care societies, even one that I'm external consultant for, that are going to encourage you to use it because remember, it benefits that particular population group. So you have to be very um, cautious. It's kind of like telemedicine for me. When somebody says, well, the telemedicine association said, I'm like, of course they did. That's their association. They're telling you to do that because that works for them, not necessarily for you. But bottom line is have an internal policy, figure out what is going to be appropriate for your practice and your patients, and try not to make it generic or one size fits all. That's only the best advice we can give until they come out with more published guidance or more direction.
All right. As always, I think that was a great kickoff topic. I know there's a lot of chatter going on across LinkedIn, across the internet, through the different listservs. I know we've seen some on the NSC HBC asking questions. We've seen some on different sites. There was an interesting comment that was posted, and I'm not going to bring it up, uh, as far as who posted it, but I'm sure several people saw it because I know a couple of folks on our panel have commented on it. But look, trying to take a new code that adds additional reimbursement to an evaluation service without achieving the medically appropriateness of adding that code, the medical reasonableness, the medical necessity of adding that code. If you're doing it simply as a way to quote unquote balance out the reductions in the payments that are being made because they've been reduced by the payers, that is intent.
Sean, what was that company in Florida? It was a big co-op. Remember when telehealth is like last year, a year before, everybody might know, and they were telling their clients, they got in big trouble with the OIG because they said, "Oh, add on 2 telehealth visits a month to help you with the COVID recovery." I'm like, "Whoa. Oh my
Somebody
God."
said
Yeah.
that to my
You know,
mom during
Oh,
COVID. We're having a
like,
her
what?
primary care doctor said we're having a decrease in reimbursement, so we need you to participate in telehealth visits.
Yeah, yeah. When I
well,
see
I'll
when I
give you
see
an
posts
even
like this, oh,
I'll give you an even better one. Um, um, give me and the acronym is RPM, right? The monitoring service
Remote
and
physiological
Remote
monitoring.
patient. Yeah.
right. So it's
or remote
no
patient
secret,
monitoring.
you
Yeah.
know, I struggle with cardiovascular disease. I've had my fun, and I have 3 stents put in, and I get to take a lot of different heart medications, which is always a joy. But here's the crazy thing. Um, a doctor who I don't even go to, okay? He just happened to be the interventional cardiologist who was on call at the hospital when I had my attack, and he put in my first stent. Um, mind you, I've not seen this doctor in probably 4 years, okay? I got a phone call in December from their office saying, "We are now offering this remote physiological monitoring, and we'd like for you to come in and get one of these devices, and we'd like for you to participate in the program." And I'm like, "Are you absolutely kidding me? You're not my provider. You've never taken care of me other than putting in the initial stent. Can you imagine how many of these beneficiaries, these patients, are getting the same phone call and who are probably unnecessarily being pushed into an RPM program?" Folks, if something sounds too good to be true when a vendor calls you and says, "We have a new way for you to make a whole bunch of money," you should hang up the phone or you should ask them to leave your practice, because nothing good typically comes from those conversations. Scott, I'm going to give you the last word on this, and then we're going to move to our next fun topic.
Yeah, I just had to, once you said that, I had to talk about this. I want to choose my words carefully, but I was involved in a project, not primary care, which I think is important. And Stephanie, you know a little bit about this because we talked about it. This was an RPM project, very similar to what you're talking about. So the vendor, this organization had basically contracted with a vendor to run RPM. And when I went to the vendor's website, because I'd done the review and I was kind of like, it did not come close to passing the smell test to me. And I went to the vendor's website and it was about obesity management. And the vendor said, we start the program by entering every patient with a standing order to lose 10% of their body weight. And, it's like a scale. And this, I'm reading the notes from the group that I'm auditing, and the providers, no mention of obesity in the charts, no plan for the obesity. And it was just a relationship that an alignment was made, where it was kind of like everybody could get a taste, as I like to say. And I just, tread very carefully in those kind of relationships. Because I couldn't see in a lot of these charts that I was looking at, I couldn't see any role for the providers for this system in the actual management of the condition for the patients. And it was not primary care. And like I say, it was really just, it was like a handoff, right? It was kind of like, I'm going to get you in this program. And, the patients would come in after they had started the program. So a patient would opt into it and they would get their scale or whatever they were getting, and they would come back in to see the provider, and the provider still wasn't mentioning the condition. And I'm talking to this group and I'm like, well, how are you showing that you're involved in this condition in any way other than cashing a check for whatever this group is doing? And so, yeah, I mean, as soon as you said that, I think, whether it's G2211 or RPM, there is no, my dad, can't say how much great advice my dad gave me over the years, but the one thing he told me many, many times is there's nothing in life that's free. And I think that's an
That's right.
important thing to remember whenever things sound good and easy.
Absolutely. And to Christine's point, the same thing for chronic care management. Absolutely. All right. I think that was a great first topic. Let's go and move into our second topic, and I want to talk about medical students, because I know we have a lot of folks that around the country listen to the podcast when after the live stream is over, and a lot who are following us and listening to us now. But medical students are not full fledged physicians, thus they have limitations on what they can and cannot do. So, Stephanie, I want to start with you because I think you were the one fortunate enough or unfortunate enough to have an experience with someone dealing with medical students asking these questions. Was that you?
Yeah. Yep.
Yeah.
So, a couple of things with this. The first thing I want to say is we all need to remember that medical students are not equal to a resident. So, when we're talking about medical students, this means that they're still in school for this. They've not graduated, they're not doctors, they are a student. And where this gets really tricky is you will find different practices, for example, or facilities that will partner with a medical school. So for me, where I find more issues in this area, it tends to be with or not non private practices. So they're not a part of a teaching facility. They're not as familiar with everything that we follow with the PATH guidelines, everything that we know from the facility side with teaching physicians. So these are typically outside practices that have a medical school in the area, and they're being asked to partner with them, or they want to partner with them to bring students in. So where I have issues is they don't understand the scope of what they're allowed to do. And it really helps me to think of students in a way that they are there to learn and observe. There's a lot of limitations as far as what they can perform. And if you go into CMS, one of the things I want to point out first, I think it's in chapter 12 of the claims processing manual, they actually say that no services rendered by a student are reimbursable. That's very different than what we have in our residency programs, the GME programs, where they are reimbursable. So when we look to the teaching physician MLN from CMS as well, they talk in there about student E&M documentation. They don't say students can perform all of these things. They're talking about E&M documentation. And if you look closely at the paragraph as well, they go on to say that anything done from an exam or medical decision making perspective has to be re-performed by the physician who's billing for that E&M service. One of the other things that was a little scary this last week, there were some questions coming through. The practice, I'm not really involved with the client, I was just being asked some questions, but the practice is having issues, I assume, with staffing. They said that they have current provider issues. They know there's a medical school in the area, and they wanted to know what they had to do to collaborate with the medical school and how they would go about credentialing those people. So we have to remember students are observers, they're not performers. And another thing with this too, and I just had this personal experience, which really was frustrating. And I noticed some of it after the fact, and it was a little too late. But in my personal life, I had brought my daughter to an emergency department. She needed a laceration repair done. As we're sitting there in a hallway, it was busy. It was really busy. It was a small department. As we're sitting there in the hallway with her on a bed, her arm getting stitched up, I look over at the badge of the person with the needle and everything in their hand, and it's a medical student. I started a conversation with him about it. He then goes on to explain about how he had not graduated, anything else. At that point, it was really, a little too late. We're in the middle of the procedure. But I can tell you, their supervising physician was nowhere in sight whatsoever. He was not there overseeing that procedure. The hospital tried to send a bill for over $1,000 for that repair of someone who shouldn't have been touching her. And, it was very frustrating. But this is a real issue where people are thinking they're one and the same. And we have to be careful. We do not credential, they do not perform. This is not an answer to staffing issues. And one other thing just to think about as well, this gets even more complicated when we think about other even clinical staff types, because I'll get the questions as well. What do we do with nurse practitioners, with APNs, with PAs, with RNs, with nurses? And, they don't all fit into that bucket of the GME program. So that becomes more difficult. But one of the things that we can look to start to answer this as well is the state scope of practice. And, I'll say I'm not always good at researching this because I feel a little iffy. It's not like CMS where I'm really comfortable in that site. But you can go to your individual states and pull up what they allow from a legal perspective those people to perform. And remember that's after they've completed their licensing in the state. It's not
Right.
before.
So let me share something. So this is what Stephanie was talking about, and I went ahead and put this link into the chat for everybody. And here it is right here. Students participating in and contributing to a billable service must do it in the physician's or resident's physical presence and meet teaching physician billing conditions. The next part also says that students may document services in the patient's medical record. Teaching physicians have to verify, not have to, they must verify all student medical record documentation or findings, including the history, physical exam, and medical decision making. And finally, under students, the last one, teaching physicians must personally perform or reperform all billed physical exam and medical E&M decision-making services. All right. So, Terry, let me stop sharing my screen and let me come to you for some comments, and then Christine will come to you for some thoughts on this as well.
Well, so I feel like I'm going to be doing a progressive commercial. Okay, so only because you guys have all seen those, right? They're really funny. I mean, they crack me up, and they're just like, it's hard, not to be your parents. But sometimes you sit there and you look at some of these things that happen. Perfect example, and it goes along with what Stephanie was saying. I had a provider, basically, we were talking about things that they can and can't do along the lines with this G2211 was the start of the conversation. And then he was saying, well, when my wife performs the E&M services, I'm just having a little trouble sometimes. We got an audit. And I said, oh, I didn't know you had another physician or mid-level. I said, is she a nurse practitioner, PA, or a physician? She says, she's not. But she's been married to me for 10 years, so she knows how the CPT book works. Okay. So I actually said, and I wasn't trying to be flip, I was trying to be a jerk because I was so angry at that point. I actually said to my client, I said, okay, and you stayed at a Holiday Inn Express, or did she just play one on TV? What are you doing? What are you doing? So I don't understand how the physician's response to me was, he goes, do you know how expensive it is to hire a partner or to hire, a mid-level provider? And I said, yes, I do. I said, that's why you get paid for them within those services, because they are credentialed and educated to do that. And by the way, does your malpractice insurance know that you had a non-credentialed, non-medical person performing services that they had no business doing? Well, I was in the office most of the time. Oh my gosh, most of the time. Yeah, I just saw Scott's head explode, and I know, Paul's ready to. It's just people. You can't. Anybody ever see this TV show Suits? It's my favorite show. Okay, I love that show. Somebody pretended to be a lawyer and got away with it for a while, and then actually went to jail for it. But the thing you have to keep in mind is that, and it's also when people come to you and say, I am this professional, check credentials, check who they are, but do not just say because they worked in it for this long that they are also that. I did an audit for CMS years ago, and I just remember it was an audit about Incident 2 and the mid-level providers. Come to find out that they had 20 PAs and nurse practitioners, one RN, and guess what do you think happened? The RN was treated as a mid-level provider, and they were billing out all kinds of levels of service. And who do you think whistleblowed? A couple of the nurse practitioners were like, I worked hard to get where I am. That's not okay. But the doctor's response was, and there were several physicians that were behind it, that said, well, this RN has been with us for 20 years, so she's just like. You're not. So it's just very frustrating. When, to Stephanie's point, when you see people trying to get around the system, They're trying to, and I don't know if it's all about saving money. I don't know what it's about, but it's definitely not just a compliance issue. But Sean, I'll throw this to you. Isn't this a legal problem now? I mean, just a blatantly illegal thing to do. I mean, I know we're
Yeah,
not attorneys, but gosh.
yeah. Listen, here's the thing. Um, Trying to circumvent the system, trying to get around the rules, um, it speaks to intent. It speaks to the knowledge of potentially committing a crime. And depending on who's looking at it, whether it's the Office of Inspector General trying to make a determination as to whether or not they believe this was a violation of the False Claims Act, or whether it's somebody who, filed a quitam, who is alleging, healthcare fraud under the statute, USC 18, USC 1347, conspiracy to commit healthcare fraud, whatever it may be. They also look at things like, what was the mindset at the time that the violation occurred, because there's something in the law called a reverse false claim. There's a lot that's going on right now with the Cienter, as it relates to the knowledge standard with the False Claims Act. But yeah, listen, you know, uh, if you're upset with your reimbursement from an insurance carrier, find somebody like a David Zetter, or find a consultant who has exponential experience in negotiating payer contracts, and turn it over to them. Let them do a SWOT analysis to figure out your strengths, your weaknesses, your opportunities, and your threats, to then be able to go back to the contracting department of the different payers and negotiate higher rates for you. And before you say you can't negotiate with these payers, let me tell you something. Go and listen to the very first episode of season 7 from last week of the Compliance Guy with David Zetter, and listen to the results that they have received on negotiating payer contracts on behalf of their clients. All right, Christine, I'm going to come to you, and then Paul Spencer, and then I'll go into the last, because I'm going to leave Paul on the screen, because I want to talk about the one compliance topic, pure compliance topic, that I want to focus on for this episode with Paul. So let me give you the last comment on this one, Christine.
Sure. I just wanted to remind, a lot of times we don't think about what the state scope of work, or even the state scope of supervision might be. So here, I'm in the state of Florida. We have a lot of very interesting laws here. As I pause. Yeah, one of the things is only a physician can provide supervision. Recently had a case come up, and it was a licensed clinical social worker who had opened up a practice, and he owned his own practice. He hired all these licensed clinical social workers and claimed himself to be the supervisor of all these social workers who worked for him in his organization, and billed everything under his particular LCSW license as if he performed it, trying to utilize the incident to. It even brought some very interesting documents to me. It wasn't even a Medicare payer. And when it came back to it, the payer says, well, we may or may not, but it's all going to fall on state scope. State of Florida does not allow a lateral supervision of LCSWs. Might happen in another state. Who knows? But it's important that providers understand that there are regulations there that are state specific that they've got to follow as well, and that affects payment. So we'll leave it at that.
Yeah, and I think this is such a great, little saying from, our good friend. If people spent as much time and effort learning the rules that they do trying to get around the rules, we'd be a lot better off. I agree 100%. All right. So Paul, I want to go to the pure, in my mind, the pure compliance topic. And we have seen a tremendous increase in laboratory audits, laboratory prosecutions, if you will, under the False Claims Act, because so much has been made regarding the ability of a laboratory to establish the medical necessity of the services they bill. But, you know, it's not really the case, and there's legal precedent to support this, right? And there's also, guidance from HHS and OIG regarding laboratories' responsibilities. But at the end of the day, both entities, meaning HHS and the OIG, both entities push the fact of the underlying responsibility back to the ordering and treating providers. So that's where I want to finish out today. Is talking a little bit about the lessons learned thus far on laboratory services, especially UDTs, UDSs, biofires. Genetic testing is a huge one because that was a big issue during the COVID-19. So let me give you the floor.
Okay, well, the biggest lesson that I've learned, just going in, if you're a laboratory and you're trying to expand your client base and you're offering perhaps a service that is not offered by another laboratory in your area, the most important thing is to remember that it's not just gaining a client and getting that client to sign the contract. That client has to have an understanding and demonstrate a clear understanding of when they're just supposed to order a very complex laboratory test. With urine drug testing and urine drug screening, unfortunately, there is a dichotomy when you break it down to federal guidelines versus state guidelines, with some states being because they have such a problem with the opioid crisis in that particular state, they're going to mandate a much more robust testing protocol than would the Medicare program, or most specifically Medicare Advantage. So it's really important. And you mentioned genetic testing. I have a genetic testing audit right in front of me right now. I mean, it's very important that physicians, who want to, genetic testing being such a new arena and a very expensive arena of laboratory testing, it's very important that they not just pull out the old buckshot rifle to try and be a sniper. That's not the goal of genetic testing. Because we have such specific genomic markers that are being tested for now, you really need to focus on the specific tests or specific genomes that you want to look at for that patient's condition. Understanding that some labs are still out there offering panels, but you have to watch how those panels are built, and you really have to be super specific in your documentation as to why this testing is medically appropriate. It's more than just writing a line saying this is medically appropriate. You really have to go into the personal and family history of the patient.
Yeah. And, Stephanie, to your point, that you were making about, states being more stringent than what the payers are actually paying for. Providers are truly caught between a rock and a hard place. And one of the things that I want to say to all of those who are either watching us live or who are going to be listening to us on the podcast later, your providers need to document the reason or reasons why they believe that ordering these tests are appropriate, why they are necessary for the patients. And they need to understand that a laboratory doesn't have the ability to determine medical necessity because they're not clinicians. So they have to rely on the requisition order, the order or the requisition form that comes from the ordering provider. And providers need to respond. When a laboratory says we need the correlating documentation to this order because we're being told that the service is not medically necessary and they want us to pay back all of this money. Providers and their staff need to understand you have got to provide a copy of the medical records to the laboratory because at some point, the laboratory is going to get tired of having to continuously make refunds for providers who are failing to document appropriately. And I know you and Scott and Paul and Terry and Christine as auditors are seeing this stuff all the time. Are you seeing in your auditing adventures um,
Yeah.
um, problems with determining the medical necessity of these services?
Yeah, so one thing I want to point out too that I don't think we made clear yet today, anyways, when we talk about something like urine drug screenings, we have to remember that there's typically two different areas that this is done for. So, substance use disorder is going to be different than pain management, medications for pain management. My client with clinics specifically for substance use really had a difficult time because they were the ones who had really strict state requirements as far as the testing frequency and also the documentation. So what had happened is we were brought in after their insurance started to have issues when they were auditing the client, and they were turning a lot of the visits down. They were saying that, they shouldn't be billing at the frequency, all of these things. So when I go in to look at records, one of the things that was new to me at the time for that state was that there was a template built into the note, and they had to have those specific areas examined or gone over with the patient so many times a month. I want to say at least once a month. So what was happening is that information was looking very templated and very cloned. And then on top of it, the patients were very high risk, and in addition to that, the providers were aware of some of the high risk street drugs at the time, so they were talking to some of these patients, some of them daily, some of them weekly. They were really concerned for, the health and even the lives of their patients. So we really had to break it down, have discussions verbally and about the clinical side, what they're doing with the patients, what their population's like, all of that. Then we had to talk about what that means for their documentation, the parts that have to stay there for the state in that way, the way they can add in free texted information so we can see the differences, we can see the risk. And it really was a lot of work to show that. Now, one thing I'll say real quick, and then I'm done with the pain management side, is also remember if you are if you have providers who are treating patients for pain, but that's not your main specialty, you need to be aware of this. I say that because I had a physician, the practice reaches out kind of randomly throughout the year, and they called to ask a question, and all of a sudden they're talking about narcotic medication for pain control. And in speaking with them, they actually had not tested, they have not been drug testing the patient at all. They weren't even really aware of what needed to be in place for pain management in general. So there are different avenues, different ways that this is done, but it does all come down to the testing like Paul was talking about.
And pain management providers tend to know the score. They're checking the PDMP. They're making certain that they're not doctor shopping if they're coming in. They're making the patient sign pain contracts. You're not seeing that on the primary care end.
And two, Paul, one of the things I've noticed in pain management with some clients this year is they're trying to be more aware of, other procedures, for example, that they're supplementing. It's not just hardcore pain prescriptions. There's a lot of different avenues to it, but some still exist. The patients have been on it a long time and they're still having to monitor and maintain to some level.
All right, so that's going to bring us to the end of our first compliance and coding roundtable of 2024. I want to thank Christine, Terry, Scott, Paul, and Stephanie for taking time out of what I know are their busy audit and consulting schedules to spend time with me and with all of you, and to each and every single one of you Thank you so much for tuning in, logging on, and hanging out with us for a little while. Tomorrow, Terry and I will be back with our very first hashtag Terry Tuesday episode of 2024. I have my very first special guest interview on Wednesday with Dr. Katie Deming, who is just a fascinating story, and I can't wait to share that with y'all. So until then, remember, be good to yourself, but more importantly, y'all be good to each other. See you next week.